All right. Many of you have joined us for the first two sessions. Like I said, this is a multi-part series. We have another session on April 21st and then May 5th. So if you haven't already, save those dates. The purpose of our webinar series is to really increase your functional knowledge of HRSA's 340B drug pricing program, identify the role, if any, of the 340B drug pricing program in your viral hepatitis program, understand the roles of health departments as well as subgrantees, and be able to really operationalize the 340B drug pricing program. And today's content is going to focus on contract pharmacies and management of 340B drug pricing programs. And for those of you who don't know me or haven't sat in on the first two sessions, my name is Erin Fraudo, and I'm a public health consultant, former health department prevention manager, and 340B authorizing official and primary contact. I've navigated the 340B program for over a decade, and I'm excited to be with you, sharing lessons learned and be in the great company of NASTAD colleagues. We're going to review some 340B basics today. We're going to talk about the roles of the health department, review the registration process, and then we're going to dive into how to actually get medications. We'll talk about contract pharmacies. We'll also review some compliance considerations that you may want to be aware of in the event of an audit. And then, of course, we'll reserve time at the end for workshopping and to answer any questions. And as we're going along, feel free to also enter your questions into the chat, or if you have anything to add that you think might be beneficial to the group, please don't be shy in using your chat box. We are very friendly, not very professional. I guess I should only speak for myself. So please enter in the chat and we'll discuss and engage as we go along through the slides. And we're going to start our review with a pop quiz. Let's see if I can launch poll. Let's see. I don't see my launch poll button. Alex, you might have to help me. Oh, thank you. All right, you can see the questions there on the quiz as well as the screen. First question, what makes a provider or organization eligible for 340B drug pricing program? Choose one of those options there on your multiple choice. A second question, who should be a covered entity's authorizing official? Your choices are there as well, multiple choice. How long after registration can a covered entity access 340B priced medications? Is it the health department's responsibility to audit their subgrantees 340B program? So if you could just take a couple minutes and answer those questions, we'll talk through the answers. And Alex, I'll let you decide when to close the poll when you think most folks have had a chance, because I can't see our results. And if you missed the first two sessions, just take your best guess on these answers.
Speaking of, I popped the recordings for part 1 and part 2, the YouTube links, into the chat. When I point, I hope I'm pointing at the chat box.
Should we go over some answers?
People are still voting, so I'll give
right.
it 20 more seconds.
All right.
Good, good.
It's kind of that time in the webinar when there's a lull and you're like, oh shoot, do they want me to do something?
Or now I'm just thinking, should we have provided prizes? Or
Oh, I thought the cat meme was enough.
True.
That's a prize right there.
That is a prize, yes.
All right, closing the poll now.
Awesome, thank you. Can you share results? Is there a way to do that? Oh, there we go, perfect. Okay, Look at you guys. Perfect. The answer to number 1 is D. Provider is eligible for the 340B drug pricing program if they receive qualifying funding authorized by Section 318 of the Public Health Service Act, or they receive in-kind contributions also supported by qualifying funding. Remember, you can find out if your grant is authorized by Section 318 by reviewing your NOFO. Every NOFO has statutory authority section. You can search any NOFO and find out what section of the Public Health Service Act it's authorized by. Question. Oh, go ahead.
Are you looking at the results? I don't see the results.
I can see the results. I see host is sharing poll results.
Oh, I can't see the results.
Oh, well, we have 88% chose D. So 88% chose correctly. A few folks chose just the funding, and a few folks chose that they have a pharmacy on site or employ a pharmacy, which is not a requirement of being eligible for 340B. And then question 2, 96% chose that the covered entity authorizing official should be someone who can legally bind the covered entity and attest to compliance, which is true. That is the correct answer. Program staff who are most familiar with viral hepatitis subgrantees may serve as authorizing official if the person who can legally bind the covered entity designates that person. So it's kind of a trick question. You want to make sure that the person who signs off on all the things has all the liability. For hospitals, that's usually the CEO, CFO, COO. It is sometimes a different person for non-hospital covered entities, but you want to make sure that whoever can legally bind your organization is your authorizing official. And let's see, number 3, how long after registration can a covered entity access 340B price medication? 63% of you chose 3 months, 29% of you chose 1 month, 4% 2 weeks, and 4% 6 months. So the 63% majority is correct here. It takes 3 months after registration for your 340B designation to be active. So you cannot purchase or dispense 340B medications until your registration becomes effective. So in your planning, you need to think 3+ months, potentially, depending on where you are in the calendar year, to a quarter. You need to plan these 3 months into your program implementation. And luckily, it's not 6 months. 2 weeks would be awesome. 1 month would be better, but 3 months, they can take up to 3 months. It might happen sooner, but they do have that 3-month window there. And number 4, oh, we got a 50-50 split here. It is the health department's responsibility to audit their subgrantees 340B program. This is actually false. HRSA and Office of Pharmacy Affairs retains this obligation. Health departments are not required by CDC or HRSA to provide oversight over their subgrantees' participation in the 340B program. However, we of course recommend that health departments provide guidance regarding 340B in their prevention contracts with subgrantees, but ultimately all covered entities are responsible for their own 340B compliance. So if you're a health department and you want to write in a contract that you will audit their 340B program, that's great if you both agree to that in a contract, but there's no HRSA or CDC requirement that you do this. Awesome. Okay, I'm going to close that and we'll move on. Any questions from the pop quiz that any folks have entered?
I do not see any questions in the chat.
Awesome. We'll proceed with our review then.
Perfect.
All right. And as Isabel put in the chat, there's links to the YouTube recordings of the first 2 sessions. And as a reminder, the 340B is a federal program administered by HRSA Office of Pharmacy Affairs. It's authorized by the Public Health Service Act. All of the Section 318 grantees are under the STD covered entity type. So that's viral hepatitis, HIV prevention, and STD programs. They all fall under Section 318, which is still designated as the STD 340B designation. Covered entities must have a financial relationship with a qualifying Section 318 program, and they must either receive financial support or in-kind contributions from a qualifying grant. To be eligible to receive 340B medications, patients must receive healthcare services other than drugs from the 340B covered entity. So you must have a qualifying provider receiving qualifying funding. Then they also must be serving qualified patients. So the three-part definition must be met for every patient that's served by a 340B drug pricing program. You can see the three-part definition here. All three parts have to be met. It's not just 1, 2, or 3. There's an and, not an or. I'll let you guys read through that. I feel like I'm a broken record reading that to you guys every time. And also as a reminder that the statutory authority for Section 318 is listed in NOFOs. You can search for this information. Any NOFO that's published has a statutory authority section. I downloaded the PDF, did a Control F, and found the statutory authority section. And you can see that on your slide. I've highlighted Section 318. So if you're a subgrantee or a grantee and you're curious if your NOFO qualifies for the 340B drug pricing program, find the NOFO, do a quick search, and you will answer that question. All right, what we talked about last time were roles of the health department. So health departments may be covered entities, or they may also have subgrantees that are also covered entities. So it might be an either or and. So if you are a health department, you want to ensure that both you and your subgrantees know about the 340B drug pricing program. You want to provide guidance on what is considered a service within the scope of each CDC NOFO that you're in charge of. You want to understand how your subgrantees are meeting the patient definition. You may review their policies and procedures. You want to set clear expectations regarding oversight and compliance. You want to be familiar with how subgrantees are purchasing medication, and we're going to talk about that more today. You also want to make sure your contracts include any 340B considerations that you've learned about or have identified that might be an important part of a contract. You also want to be aware of registration and recertification periods in order to best support your subgrantees. Health department staff will need to provide grant numbers and NOFOs that are authorizing funding to subgrantees. HRSA, Office of Pharmacy Affairs, will also reach out to the state level administrators of the qualifying grant to verify that any subgrantees are in fact receiving financial support or in-kind contributions. And then if a subgrantee is no longer receiving funding or in-kind support, a state level administrator would also need to notify HRSA OPA that they are no longer receiving the support. What's not a role of a health department? It is not a health department's role to enroll anyone else into the 340B program. You do not want to be serving as anybody else's authorizing official. We want to encourage and empower other folks to enroll in the program if they so desire. You don't want to attest to another agency's compliance. You don't want to create their policies. You don't want to create their procedures. Reviewing and providing technical assistance and support is great, but it is not the health department's role to generate these. Also, we discussed in our pop quiz, auditing their 340B compliance is not a requirement. If you want to do that, great, but just know that that is not a requirement. And health department should not take all the 340B revenue. That should be discussed between the covered entity and the health department authorizing the designation on how that should be shared or split or best utilized. And again, health departments should provide guidance regarding the 340B program. Prevention contracts are a great way to do this. And just a reminder that ultimately all covered entities are responsible for their own 340B compliance. Again, what we discussed last time was there are 4 annual registration periods, the first 15 days of every calendar quarter. It doesn't matter if it's a business day or a weekend, it's the 1st through 15th of January, April, July, and October. The register button on the Office of Pharmacy Affairs information system is only accessible during these registration periods. And we discussed in our pop quiz that it takes up to 3 months to verify registration and activate a registration. So any covered entity may not purchase or dispense 340B drugs until the registration becomes effective. And ideally, each location has its own unique database entry in the Office of Pharmacy Affairs information system. This limits audit liability and really compartmentalizes operations. This might not work for how your organization is set up if you're in a centralized health department system. And of course, there's special considerations, but just remember, everybody who signs their own contracts and is in charge of their own liability should also mirror that same operationalized system for the 340B drug pricing program. All right, so now that we know about the 340B drug pricing program, what it is, we understand eligibility, we understand the patient definition, we know how to register, we know who our authorizing official is. Let's figure out how to purchase medications. Let's figure out the exciting part of treating folks. We're also going to talk a little bit about management and inventory and how to stay compliant within the 340B drug pricing program. So up here on your slide are two main ways how a covered entity purchases 340B medications. The way a covered entity purchases their medication really depends on how they're set up. Some covered entities have in-house pharmacy or pharmacy licenses. The use of an individual contract pharmacy or multiple contract pharmacies is, of course, completely voluntary, and a covered entity should first determine its need for pharmacy services and then the appropriate distribution mechanism for those services. So some covered entities will buy direct from a pharmaceutical wholesaler, and some will need to contract with a pharmacy. I put the big players up here on the slide. Pharmaceutical wholesalers include AmerisourceBergen, McKesson, Cardinal Health. You or your organization might already be familiar with these wholesalers. Contract pharmacies, again, the big players up on this slide, Walgreens, CVS, Walmart, and Accredo. They have the bulk of contracts in the contract pharmacy world. And we'll talk about wholesalers first, and then we'll dive into contract pharmacies. So if you or your agency or your subgrantee are already set up for in-house pharmacy services, it may just be a matter of setting up a wholesaler account and ensuring your tracking and record keeping are up to 340B standards. This is what many correctional facilities do, as well as family planning clinics. They already have in-house pharmacy set up, and so a 340B designation fits well because they already have a purchasing mechanism set up. Most wholesalers have a standard process for opening the appropriate accounts based on 340B covered entity type. You'll want to take this step into account when you're planning a 340B program, as this can add to your timeline. Most wholesalers will want to see your active 340B registration approved by HRSA before they'll set up an account. So you'll need to register, be approved, and then set up your wholesale account, because that wholesaler will want to see your active 340B designation. They'll also be using the 340B ID in your account. So you'll need to have that 340B ID first before setting up a 340B wholesale account. And just as a reminder, I'm sure there's lots of state administrators that already know this, but your state agency might have approved vendors. So you'll want to check to see who's on your approved vendor list and what wholesalers you might need to add to that approved vendor list. So that might add additional administrative time.
Okay, Erin.
Mm-hmm.
I'm processing, but we also have a question from Nadine. Thank you, Nadine. Does the covered entity need to already have an established contract with the pharmacy by the time they register in the 340B program?
No, you don't. And this is different than a contract pharmacy, because you do need to have your arrangements with a contract pharmacy already set up. A wholesaler is not entering into the 340B database. They're already a wholesaler. They already have all their stuff taken care of. So when you register as a 340B covered entity, they're not really going to worry about how you're accessing medications unless you also have a contract pharmacy under your wing as well. So you can register, get your ID, reach out to your wholesaler. And I'll be honest, wholesalers can take their sweet time setting up your 340B account. So be great activists and make sure you have a good point of contact at that wholesaler, because you'll need to follow up. Sometimes it can stretch out a really long time because they're not making a ton of money on these 340B medications.
Okay, good. Thank you.
Yes.
Thank you, Nadine, for the question. All right, let's keep going.
Okay, and again, auditable records. If you are already set up with in-house pharmacy and you already have some sort of pharmacy license that allows you to purchase and dispense or administer medications, you'll want to keep auditable records. That includes anything from start to finish that has a number that you need to document. This includes NDC codes, NDC numbers. You want to make sure you know who got what and from what lot number. So whatever records you feel comfortable of somebody else coming and asking, okay, I see this medication coming in on this date, where did it go? And you need to be able to show that line of where that medication went and make sure that you can demonstrate that the patient was eligible to receive that 340B medication. So some people use their EHRs, some people have a separate 340B log, anything that is visible. It's documented, it's not just in somebody's mind, it's not jotted down on sticky notes that could be lost, something that you feel confident that you can reproduce and show HRSA OPA in the event of an audit. All right, if we have no other wholesaler questions, we're gonna dive into contract pharmacies. Great. So a lot of covered entities choose to access medications using a contract pharmacy. Sometimes this is the only way you're going to get medications into people's mouths or arms or butts or wherever else medications go. I meant injection. Sorry to clarify, injections in the gluteus. All right. If the concept of a contract pharmacy also terrifies you, I just want to remind everybody that Ryan White programs and AIDS Drug Assistance Programs, or ADAPs, have been working with contract pharmacies for decades. If you're at a state health department, reach out to your ADAP friends and capitalize on their years of experience with contract pharmacies. A lot of ADAPs also use pharmacy benefit managers, or PBMs. So depending on how complex or how large your 340B program is going to be, a PBM or a pharmacy benefits manager might also be useful. But your ADAP friends can talk to you about who they use, the pros, the cons, all their tips and tricks. So I just want to encourage you, in addition to NASDAD and RTA, you might have in-house knowledge as well about contract pharmacies. And also, contract pharmacy operations can get quite complicated. So for the purpose of this webinar, I'm going to provide you with an overview and functional knowledge. And if you have a more in-depth question or you would like technical assistance specifically related to contract pharmacies, please reach out to us and we'll take care of you. We'll make sure we provide you with some technical assistance. And Isabel will put the email again in the chat if you need to email us a TA request. A contract pharmacy arrangement, again, broad view, is when a 340B covered entity signs a written contract with a pharmacy to provide pharmacy services. Using a contract pharmacy model is sometimes the only way a covered entity can access 340B medications. Like I said, unless you have in-house pharmacy, unless you have a pharmacy license, a contract pharmacy might be your default option. Contract pharmacies can also increase patient access to 340B medications if the pharmacy is conveniently located to patients. Contract pharmacies also eliminate the cost of operating an in-house pharmacy. However, there's dispensing fees that should be a consideration when contracting with any pharmacy. It's a big part of a discussion when you're entering into a contract with a contract pharmacy. Contract pharmacies should also be thoughtfully considered. They are not all equal and there's a lot at stake. There is a potential large amount of revenue that could be generated. So you want to make sure you have a trusting relationship with a contract pharmacy. And I put some dispensing fees up there as an example. I found this information in the National Association of Chain Drugstores. They have a national cost of dispensing survey. The latest data was from 2018. The average cost of dispensing was $12.40. For a specialty drug, the cost of dispensing was almost $74 per dispensing. So that would be a dispensing fee that a covered entity would pay to the contract pharmacy to provide those medications to their eligible patients. And like I mentioned, there also might be a third-party administrator involved. A pharmacy benefits manager really acts as that third party between the covered entity and the contract pharmacy, and they verify patient eligibility, and they are kind of a safety net to make sure that there's no duplicate discounts happening. So usually they operate with very complex software and databases, and it's that communication system between covered entity and contract pharmacy to verify eligibility. And again, I just really want to drive this point home. Ultimately, compliance rests with covered entities. So you are vouching for your contract pharmacy. You should evaluate the model that your contract pharmacy operates before you enter into a contract, and make sure that you feel comfortable with how they operate with 340B. Even if the contract pharmacy is already an established contract pharmacy for other covered entities, you want to make sure that they're still familiar with your covered entity type and that they register with your specific contract agreement in place. So if I'm a covered entity, I don't want to assume that Walmart knows how to serve my STD patients, my STD designation patients. I want to make sure I sort everything out with them, that they understand everything, that they're not going to charge me an exorbitant fee, that I feel comfortable with how they're managing their inventory, that they're going to be able to prevent duplicate discounts. I want to make sure they understand my patient's eligibility requirements. I want to see their tracking system. I want to understand how they're going to reconciliate their dispensing and their purchasing and their billing records. I want to see quarterly or monthly reports of my patients that they're serving. I want to know all of this before I sign a contract with them. And again, fees are a big thing to discuss, as well as savings and revenue. You need to outline in a contract that that revenue or savings belongs to you, belongs to the covered entity, not the contract pharmacy. You do not want the contract pharmacy to keep thousands of dollars that belong to the covered entity. I see Isabel's very pensive face. Do you have a question, or are you just processing? Okay. Okay, perfect. And also for you guys to be aware, the Office of Pharmacy Affairs may request a copy of your contract pharmacy service agreement. So just like we discussed in our previous session, make sure your house is in order before you register as a 340B covered entity. Make sure you have your contract signed, your pharmacy agreement sorted out, everything's negotiated, you know what kind of fees there are. All right, let's walk through an example. This kind of looks like Edwin. Edwin, are you a pharmacist? All right, in this example, the Townsville Hepatitis Alliance is the covered entity. Even though they contract with a pharmacy, they are still responsible for program compliance. They purchase hepatitis C treatment medication in a bill to, ship to arrangement, meaning they purchase the medication, they get billed for it, and then the medication is shipped to the pharmacy, and the pharmacy stores it for them, secured location, and they're going to be responsible for dispensing that medication. The contract pharmacy stores the medication in a completely different physical space and dispenses the medication once a patient is deemed eligible. This is a small town, a small operation, so there's no third-party administrator or pharmacy benefits manager. The contract pharmacy and covered entity verify patient eligibility over email, with Townsville Hepatitis Alliance letting the pharmacy know who they've started on treatment and who will be coming in to pick up their medication. There's a hard copy printable email that is verifying eligibility between the contract pharmacy and the covered entity. The contract pharmacy service agreement stipulates that if there is any revenue generated from privately insured patients, that the contract pharmacy forwards the full amount of collections to the covered entity and then bills separately for a $25 dispensing fee. In this instance, there are two transactions happening. The contract pharmacy is forwarding the amount collected from insurance to the covered entity, and then the covered entity is paying the contract pharmacy's invoices for dispensing fees. Any questions on that example? It's very basic, it's very simple. It's very rarely that simple, but I wanted to give you guys a functional knowledge of how these interactions are going to be happening with a contract pharmacy.
So is that okay? I'm sorry, how was I supposed to write in the chat, this is Nadine? Can you hear me?
Yes, please, go ahead.
Is it better to have two transactions as you are describing here, or should the pharmacy deduct the dispensing fee for that month for all the prescription dispensed that month, and then give the rest or send the rest of the money to the covered entity?
I would recommend keeping it two separate transactions. You don't want to give any illusion that the pharmacy is entitled to your revenue or savings. So I would recommend two separate transactions. This is a little bit better in an audit situation where you can demonstrate the payment of dispensing fees, and then the revenue is coming back to the covered entity. That would be my recommendation. But you might want to consult your legal department, or the contract pharmacy might also have strong feelings about this. So it's definitely a point of conversation.
That's a great question.
Okay.
Really good question. Thanks, Nadine. Anybody else?
I don't see anything.
Awesome. There also might be a lot of questions about beyond the brick and mortar situations. We know there's mobile units, telehealth has been big due to COVID, and also street-based care. So for every special situation that you cannot find clear guidance on, I would encourage you to reach out to Apexis Answers. They're experts, they translate and communicate HRSA policy. So if you have a special situation, of course you can reach out to us, but there's also Apexis Answers. So if you're already a covered entity, I love using Apexis Answers because they have a live chat, as well as you can call somebody on the phone and get a live human being to talk through things. Sometimes they won't give operational recommendations because they translate HRSA policy. So if you're wanting to know, operational considerations or theoretical situations, they might not be the most helpful, but it's also a great resource. So let's bring back some 340B basics to talk through mobile units, telehealth, and street-based care.
Well, we have a very important point that Rachel brought up in the chat. So it seems like you would need to have money to pay up front for dispensing fees before you have generated savings to use to pay the dispensing fee. Interesting.
Yes. Yes, you would. And this might be a limitation, especially if the medications are a lot of money. So this is definitely a consideration in your program planning and a consideration in this model of generating revenue.
Great point.
Yes, really great point.
Yeah, myself included. Okay.
All right. So remember, for an organization to have access to the 340B program, they must be receiving the qualified federal support or funding. And for patients to receive 340B medication, the covered entity is providing healthcare services other than drugs. So patient eligibility is met when the covered entity has an established relationship with the patient, maintains records of their healthcare, and an employee or paid contractor of the covered entity is providing the care. They also maintain the responsibility of care, and the individual is receiving healthcare services that are consistent with the intent of the grant. All of this still works if somebody is doing street-based care or is operating a mobile unit. If they're a qualifying provider serving qualifying patients, as far as the 340B program is concerned, it doesn't have to be in this building up on your slide. It all still works if you're beyond the brick and mortar. And an example of this would be for Organization X, who is already a qualifying provider. They're already enrolled in the 340B program, and they've started conducting hepatitis C and HIV prevention, testing, and linkage to care on an outreach basis. They are meeting people where they are, which is a best practice. It's a impactful intervention. So the outreach specialist is out and about doing these new grant activities, and they connect with Sarah and Jack. The outreach specialist has been seeing Sarah and Jack weekly for syringe service programs, and today during the routine risk assessment, they have discovered that Sarah and Jack are ready to receive hepatitis C testing. They also notice pretty significant abscesses and wounds on their arms. So the outreach worker texts her manager or their manager at Organization X and dispatches the mobile healthcare unit. Organization X has an established relationship with both Sarah and Jack. They see them every week for services. Sarah and Jack are receiving healthcare services from the outreach worker, who is an employee of the covered entity, and Sarah and Jack are receiving healthcare services that are within the purview of the qualifying grant funding, having a risk assessment, being asked about their hepatitis C risk every week, and engaging in that with that outreach worker during syringe service programming. So the PA arrives, the mobile unit, the mobile healthcare unit has been dispatched. The PA arrives and provides wound care services and calls in a prescription to the contract pharmacy around the corner. Sarah and Jack are able to go pick up their prescriptions, and Organization X receives a bill from the contract pharmacy for the dispensing fee. All of this is documented, and all of this is outlined in Organization X's policies and procedures that are sitting in a 3-ringed binder in the manager's office. All of this still works. All of that is still operating within a 340B framework. What questions do we have about that scenario?
Let's give folks a few seconds.
And Sarah and Jack's wounds heal beautifully. They're provided wound care supplies, and they feel loved and valued, and it's a harm reduction success.
Okay, from Rachel. What about people who you might not see again? Lots of people at SSPs are transient.
As long as you maintain a record of their healthcare interaction with you, if they're lost to follow-up or a transient population, it still works. And think of this as in context of maybe a community health center or a homeless clinic. They have the same issue, and they still operate, still maintain records, still provide services. So it still works. You want to make sure the interactions you do have with folks, you do document, and document that they're transient, lost to follow up, any information that you do have. And Rachel, it was Rachel that asked this question, right?
Yes.
Rachel, as I was thinking through this, I was putting it in terms of SSP programs as well, of like, oh, harm reduction programs and SSPs really value confidentiality. And sometimes you don't know people's first and last names, and they just go by a code. So you really have to put all of your programming hats on and decide what's the best. So in this instance, Sarah and Jack were just receiving syringe service programs until the outreach worker identified their wounds. And when the PA got dispatched and the mobile healthcare unit got dispatched, then Sarah and Jack would need to disclose their name, their information, to be part of a medical record. So in this instance of Organization X operating both healthcare and SSP, a program administrator would need to use their judgment and discretion of when to move somebody from anonymous SSP interactions to an auditable healthcare record if they're receiving 340B medications.
Thank you, Rachel.
Yes.
We are going to move on.
Okay, cool. All right, we're going to talk about some compliance elements. If and when you're audited, these are the program requirement categories that HRSA will be looking at. They are going to look for comprehensive written 340B program policies and procedures. Again, they need to be written and documented. You can't just be like, Erin's our 340B person. Erin can tell you all about our policies. That's not going to fly. They want it on paper. You're going to want to document your program requirements, your methodologies for routine self-auditing and internal corrective action. You need to have a plan for when something goes bad, that you can fix it. You can identify it and then fix it. You need to have any contract pharmacy agreements outlined in an auditable record. Also, 340B Office of Pharmacy Affairs Information System record. It's a one-page kind of ID card that you can find in the database. They also want to know that you are taking every measure that you can to prevent diversion. So you want to document how your 340B medications are not going to ineligible patients. You want to also document that you're not reselling or transferring 340B medications. You also want to demonstrate that you're preventing duplicate discounts. And all of this information is also on HRSA's program integrity guiding principles to maximize oversight and manage compliance risk. There's a link Isabel will drop in the chat, but if any of this is super overwhelming or you want to read through things, I really like to read through things several times before it sinks in. That website is very, very, very helpful. And also, it's a recommendation that 340B covered entities conduct internal audits. Also, independent audits are recommended. The Prime Vendor Program has auditing tools as well as a contract pharmacy checklist. And if you haven't been to the 340B Prime Vendor Program website, that also has a lot of resources and tools. And again, maintain any written policies and procedures that describe contract pharmacy oversight activities. That includes patient eligibility determination used at the contract pharmacy, reconciliation of dispensing, purchasing, and billing. And again, you can use the self-disclosure tool to disclose any violations found while using, I didn't finish my sentence, while using the self-auditing tool. And all of these will be on your resource slide at the very end of this presentation. And again, another plug for the Prime Vendor Program. In addition to negotiating cost savings with manufacturers, the 340B Prime Vendor Program, which is managed by Apexis, provides education both online and in person, and 340B University is also very helpful. It's really tailored to all covered entity types, so a forewarning, it may be very overwhelming when you're learning about hospital types and things that you're not familiar with, but they also provide a lot of great context, a lot of great working knowledge, glossary of terms, things like that. So if you're not familiar, I would look into the 340B University. They also provide on-call assistance that aligns with HRSA policy and guidance. Like I mentioned earlier, Apexis Answers provides both phone and live chat support. I really like the live chat support because you can save it and it's written down and you can share it with other people. But they're really helpful for almost any issue a covered entity would have.
Erin, are all of these services free?
Yes, yes, they are funded through HRSA Office of Pharmacy Affairs to provide this TA. So this is the person, this is the company that HRSA contracts with, so they don't have to take all of your questions. So Apexis Answers and the Prime Vendor Program is funded directly from Office of Pharmacy Affairs to be this TA service provider for the 340B program. And like I said, they're for all covered entity types, and since hospitals take up 80% of this program, that's really where you'll find a lot of the material focused towards. But with that being said, lots of great resources. You'll just have to use a little bit of critical thinking to see how it applies to you as a grantee type, a Section 318 grantee type.
Got it.
And also if you do reach out to the Prime Vendor Program, they'll ask if you have a 340B ID or if you're a covered entity. They still will help you if you're not, but if you are a 340B covered entity, they'll want to know your ID number so they can give you more tailored and specific TA or kind of some more context for them answering your questions. All right, and again, while not an exhaustive list, these are some very useful resources for viral hepatitis programs specific to contract pharmacies. There's contract pharmacy FAQs, program integrity, like I mentioned, for audit considerations from HRSA, self-auditing tools. Also, the Community Health Center organization has really great resources for contract pharmacies. A lot of community health centers use contract pharmacies. And of course, Apexis Answers and the Prime Vendor Program, which I've mentioned throughout this presentation. And to summarize our learning points today, covered entities are free to choose how they provide 340B pharmacy services to patients subject to federal and state laws. That includes contracting with a retail pharmacy, providing in-house pharmacy services, administering medications to patients. Covered entities are responsible for compliance even when using a contract pharmacy. So different than state level and subgrantees where there's a clear differentiation, there's not that same buffer when you're a covered entity having a contract pharmacy. Your contract pharmacy is acting on your behalf. They are a covered entity agent. So you are responsible for compliance even when using that contract pharmacy. And there are many contract pharmacy related resources available through the 340B Prime Vendor Program. So if I sent you into any spirals, know that there are resources in addition to us out there to help you. And that's it for my formal presentation. I think we have about 10, 12 minutes to answer questions. And this part of the webinar is specifically for health department and community-based organization staff and viral hepatitis, HIV, and STD programs. So if everyone else could log off to ensure our health department and CBO participants feel comfortable asking questions, we'll do some workshopping and engage with any questions. And I'm really looking forward to our next session, which is Wednesday, April 21st, same time. And we're going to talk about 340B implementation among viral hepatitis programs. And we're actually going to have Health Department and Department of Correction friends from California, Iowa, and Utah to discuss how they're actually implementing this, how they're leveraging the program. There'll be real world examples. It'll boost your confidence that if they can do it, you can do it. And I'm really looking forward to hearing how they're stretching their resources as far as they can go and expanding their hepatitis programs.